Good evening, viewers. On behalf of Doc Plexus, I'm Kajal Mukherjee. Welcome you to this podcast. Diabetic retinopathy remains one of the leading causes of vision loss in adults, adding significantly to the global burden of diabetic related complications. Progressive microvascular damage in the retina can result in the vision threatening conditions such as macular edema, vitreous hemorrhage, and retinal detachment if left undiagnosed or undetected. For clinicians, early detections through regular screening, timely referral for ophthalmic evaluation, and optimal glycemic and blood pressures controls are crucial to preventing irreversible visual impairment and improving patient outcome. Today, joined Dr. Mihir Vaidya, a proficient Vitreo-Retinal surgeons and consultant ophthalmologist for our podcast in ophthalmology and gain valuable insight into diabetic retinopathy. So welcome, Dr. Vaidya. It's over to you. You can
Hello.
give a brief introductions about you.
So I am Dr. Mihir Vaidya. I am a Vitreo-Retinal Surgeon, as you just said. Apart from that, I am a consultant ophthalmologist and I am currently working in Mumbai. I am associated with Sion Hospital, where I work in the mornings, and in the evenings I have consultations in Kandivali. I visit Gulmohar Eye Clinic, and I have completed my surgical Vitreo-Retina fellowship, which was a long-term fellowship of 2 years from Arvind Eye Hospital, Pondicherry, and I have also worked in Shankara Eye Hospitals. Apart from that, I was working in Bachchu Ali Eye Hospital in Parel, which is a very good trust hospital. And we have been dealing with a lot of retina patients in there as well as in Sion Hospital.
Thank you very much, sir. So, sir, to begin with, we'll take a perception in the how it is globally available. So, how significant is the burden of diabetic retinopathy in India and globally? So, are we seeing a rise in prevalence with increasing diabetic cases?
So, yes, diabetes is something which has become very common now. And globally, also, it is a big burden. We will talk about the numbers in India today first. And that is, if you see, India has a population of around 1.5 billion. Out of that, around 77 million people have type 2 diabetes, which happens because of insulin resistance. And around 10 lakh, that is 1 million people, have type 1 diabetes, in which the insulin production itself is hampered. This type 1 diabetes starts at a very young age and can be observed even in children as well as young adults. So, if we look at how diabetes affects the eye, 1 in every 4 people who are living with diabetes, they have some or the other ocular involvement, especially diabetic retinopathy. And diabetic retinopathy can be mild or it can be severe. 5 to 7% of these people actually have sight threatening forms of diabetic retinopathy in which the vision can be lost, slowly decreases, and is lost forever if not treated in time. So, yes, India does have a large diabetic population, and with increasing population and uh, other factors, this is always going to keep on increasing.
So that's interesting. In fact, for today's sessions, many will be benefited because, as you said, there is a good prevalence. So, could you explain the underlying pathophysiological mechanism leading from chronic hyperglycemia to retinal microvascular damage?
So, chronic hyperglycemia means an elevated sugar level in your blood vessels and your entire body, which happens in diabetes. What happens is when the glucose levels or the sugar levels are elevated for a long time, it leads to accumulation of sorbitol as well as advanced end glycation products in small vessels. That is the microvascular disease, as you just said. The small vessels of the body, especially in the kidneys, the heart, as well as in the eyes, in the retina especially, it leads to accumulation of these products. Also, there is oxidative damage because of diabetes and inflammation which is associated with it, which leads to a leakage from these vessels. So normally the walls of these vessels are tightly enclosed and there is no leakage out of these vessels and when they are completely functional. However, when these microvascular changes occur, for example, the cells which are very tightly bound in the walls of the vessels are called pericytes. Now, when there is a loss of pericytes, what happens is blood, proteins, exudates, all these things, they start leaking from the vessels and start getting accumulated in the tissues around it, which is called swelling of the tissues around the blood vessels due to leakage from them, which is nothing but macular edema. Similarly, diabetic retinopathy can be divided into proliferative and non-proliferative types. So, in the proliferative type, which is actually very severe, what happens is there is a global ischemia, global as in the entire retina is supplied by small vessels. Similarly, the kidney is also supplied by small vessels. So, what happens is when there is ischemia, what I mean by ischemia is when enough blood flow is not happening and we are not providing enough blood and thus enough oxygen to these tissues. These tissues are always in a high oxygen demand. They want more oxygen, but they are not getting it. So then what happens is there is haphazard production of new vessels. It is like a panic mode for the eye, where blood vessels are suddenly being generated, but they are not being generated properly. And these vessels are neovascular vessels. These are not strong vessels like the ones which we have normally, but these are very friable. They can break, they can burst, they can leak, and that is what causes bleeding in the eye, which is known as vitreous hemorrhage. So, overview of the pathophysiology is that damage to the walls of the blood vessels, causing leakage from all these blood vessels, leading to accumulation of different products like exudates, saline, and edema, water in the tissue surrounding it, and proliferation of abnormal new vessels, which is leading to bleeding in the eye. This is the overview and a simplified pathology of diabetic retinopathy.
Nicely explained, sir. Sir, how do you classify diabetic retinopathy, that is henceforth we call DR, or and diabetic macular edema, that is DME? So are there
Okay.
any newer or simpler simplified classification systems being adopted in clinical practice?
Yes, yes. So, diabetic macular edema. Edema means swelling, as we just discussed. So, edema happens in the macula, which is the centermost portion of the retina and is responsible for the vision. So, when edema happens, the function of the centermost portion of the retina, that is the macula, it decreases and it results into a loss in vision. So newer classifications, I'll get a bit technical in this. Early on, what we had is we had only this thing that we could visualize the retina using a direct or an indirect ophthalmoscope after putting drops in the eye and dilating the pupil. So all the classifications of clinically significant macular edema or edema with hard exudates, sursynate patterns or not, were based on our visual interpretations. But now what we have got is an OCT scan, that is an optical coherence tomography. So we all know the CT scans or MRIs, which are being used for the entire body. Similarly, CT scan is a computed tomography of the retinal layers. So it focuses on only the retina, which is the innermost portion of the eye, and gives us a cross section of all the layers, all the small layers of the retina. So it tells us whether the shape of the retina is normal. Is there any abnormality detected in the form of accumulation of hard exudates, hemorrhages, or is there any tissue swelling in the retina, whether it is affecting the center or not? So broadly, we classify it as center involving diabetic macular edema, which leads to a loss in vision, and non-center involving diabetic macular edema, which does not really lead to a loss in vision, but can become central anytime if the diabetes is not controlled and the damage progresses. So one portion is done, that is diabetic macular edema. The second thing is diabetic retinopathy. Broad classification is non-proliferative and proliferative. So, proliferative is when abnormal vessels, which are friable and not very strong, they start proliferating in the eye because of ischemia, which is reduced oxygen supply. And non-proliferative is any diabetic retinopathy stage before it leads to the before it goes into a proliferative stage. So a non-proliferative stage can be broadly classified as mild, moderate, and severe, so that we know how severely the non-proliferative stages are there, and they can progress to a vision-threatening form. So there are a few changes in the eye. What happens is the, when the blood vessels start leaking or become strong, they just burst. There are hemorrhages in the eye. There is accumulation of hard exudates in the eye, and there are microaneurysms. Depending on how many are there, we classify as mild, moderate, or severe. Also, there are intraretinal microvascular abnormalities. There are venous loopings and dilatations and number of hemorrhages. So that is the criteria used for severe. I'm sorry, I cannot hear your voice.
Sorry, sir. Actually, it was muted. So, coming to the screening guidelines, what are the current screening recommendation for diabetic retinopathy, and how early should screening begins after the diabetic diagnosis, or maybe a patient becomes diabetic?
So, as we said, there are two types of diabetes, type 1 and type 2. Type 1 occurs in young people, so it is safe to screen within the first 5 years after detection of diabetes in young people. And why do I say so? Because it is detected early, and it is detected usually as soon as or within a couple of months or within a year of when the damage starts happening. But for elderly people, the more insidious form, that is type 2 diabetes, which is related to insulin resistance. We never know since how many years his sugars have been elevated. So we have to screen for the diabetic retinopathy as soon as the patient is detected with diabetes. But practically, I would say that if you are detected with diabetes, there is no harm to get a screening done. Why should we wait for anything? Why should we be so rigid about these guidelines and take a risk on our eyes? So I would suggest that if you get detected with diabetes, annual screening of for whether any changes of diabetic retinopathy are present or not, that is once every year, should be mandatory so that we can detect diabetes as soon as it is in the mild non-proliferative stage or not reaching anything. And why it is important is that diabetes can stay undetected for a long time because it does not necessarily have to produce symptoms. Diabetic retinopathy also does not necessarily have to produce symptoms. So we have to catch it. If we have to catch it at an earlier phase, which is very ideal, then we should screen as soon as the patient is detected with diabetes.
Very well said, sir. So, because absolutely important message for the any patients, I mean, seeing this, that whenever the diabetic is diagnosed, it is mandatory to do an screening for diabetic retinopathy. Similarly, our diabetologists, ACP, I mean, diabetologists who are maybe seeing this, they must also look into that. If the patient is diagnosed with a diabetes, immediately should refer for diabetic retinopathy. So exactly
Yes.
my next question to you regarding this, that how can a non-ophthalmic ACP like diabetologists contribute to the early detection and referral of the patient with diabetic retinopathy?
Okay. So in India, whenever a person gets diabetes, it is not necessarily that he goes to a diabetologist only to control his sugars. It could be anyone. It could be a general physician, a very experienced general physician who is in practice, or any general physician, any MD physician, or any diabetologist, or if he's being treated by any kind of doctor for any ailment. The thing is, it is very basic and it is taught to all of us during our MBBS that you have to ask for systemic history. So whenever you get to know that the patient is having diabetes, he might have a fever right now, but he has diabetes for 5 years. It is our job as primary clinicians to ask the patient whether he has undergone any screening for diabetic retinopathy or not. Because the thing is, an eye is the only place in our body where we can directly visualize the blood vessels. See, diabetes is affecting everything. It is affecting the kidney, your heart, your this thing, your eyes, but you cannot actually see the blood vessels in your kidney or heart. So it is very difficult to detect unless some functional damage happens, or your creatinine gets raised, or you get a chest pain or something, some blockage happens. Till then, it is very difficult to detect it in any other organs. So if you have diabetes, and a person, if a patient, if a patient is coming to a clinician with diabetes, then he should always refer it. And if the diabetic screening is not being done annually or he has never done it, then everyone, any doctor can refer it to a ophthalmologist, or a vitreoretinal surgeon. That would be even better. So that would be the job of a primary care physician or a diabetologist or any doctor as such.
Thank you very much, sir. Sir, you have already explained about OCT, so I will just remove that part. But how have imaging technologies like fundus photography or maybe AI-based retinal screening changed the way we detect and monitor the diabetic retinopathy?
So fundus photography, it's basically uh, taking pictures of the fundus, what an ophthalmologist sees using a binocular indirect ophthalmoscope, or after putting drops using any method of examination, he can use a 90 diopter lens or a 20 diopter lens to see it. But sometimes what happens, it becomes very difficult to document and then say, if a patient is coming to me after 6 months, it is very difficult to remember the exact picture of the patient after 6 months because I am seeing around 20 patients every day. So, a comparative analysis with the last screening that was done becomes very important. And now we have that. We don't have to rely on just the diagnosis or whatever is there at that very moment. We can say if it is progressing or not, if the number of hemorrhages, number of vascular changes, the severity of these changes has slightly increased, it is stable, or the patient is having a good control, so it has decreased and the eye is actually improving. So for that, fundus photography becomes very important. The second use of fundus photography is in telemedicine. So if in a rural remote area, I, as an ophthalmologist, cannot directly go there and see patients. But if they are sending me images, then I can definitely comment on them and say whether he needs a detailed screening or not. Then he can consult an ophthalmologist wherever he is. With whoever is closer to him, he can consult a retina surgeon or an ophthalmologist to get further evaluated and diagnosed. And nowadays, early on, the quality of fundus pictures which was available was not so great that you could completely rely on them. Now it has become so good that sometimes a fundus picture tells you more than what an examination can tell you if it is of that quality. Because it is a picture where you can zoom in, you can increase the brightness, some lesions which are being missed because the patient is, say, uncooperative, completely moving his eyes during examination, can be picked up on a fundus photograph. But the most important thing, according to me, is documenting so that we can compare with his visit, which was say 6 months back or 1 year back, if any changes have occurred, if they have increased or decreased. So fundus photography is done. Another investigation that we usually use is fluorescein angiography. So what is fluorescein angiography? To detect whether any leaky vessels are there in the eye, what can be done is that a dye can be injected in the cubital vein here, and that dye travels through the body and reaches the eye. Now, special excitation and blocking filters can actually fluoresce the dye. Fluoresce means it can illuminate and it can be a very nice, contrasting, glowing dye can be seen in the eye, traveling while it travels. Multiple serial images can be seen and they can be compared to see if there is leakage at any points. So sometimes what happens is the leaky vessels are so small that they are missed by the naked eye. So, in such cases, if you have doubt that the patient might actually be in a proliferative stage, a fluorescein angiography could do wonders and detect diabetes early. And that is what guides the treatment later too. So, that is another thing. One more thing is OCT angiography. This is the latest development and it traces the blood vessels. So, here in fluorescein angiography, what was happening is we had to inject a dye so that the dye was moving through all those blood vessels and we could pick the image off by shining light on it and then it being glowed and the image being reflected to us. But now we don't have to do that. OCT angiography is a completely non-invasive technique. By non-invasive, I mean there is no need to inject any dye. It directly senses the motion of blood vessels. It takes a lot of scans in per second and it sees the motion of red blood cells moving through the blood vessels. And it gives us a picture of the blood vessels, not just the view from the top, but also a scan, like how OCT was giving us a cross section. So, which vessels are affected, whether they are the superficial vessels whether they are the vessels in the middle layer of the retina or the deeper vessels. Even that information can be gathered from doing an OCT angiography. So these are the most important investigations that are there. And further, there are some situations in which the diabetes has progressed. The proliferative diabetic retinopathy has reached a stage where vitreous hemorrhage has occurred, that is, bleeding into the vitreous cavity. So our eye is filled with vitreous. Vitreous is a gel which fills up the eye. If there are blood vessels which are friable and they burst open and they start bleeding into the eye, the blood is going to accumulate in the vitreous cavity. So what will happen is, when we try to examine the retina of that patient who has blood in the vitreous cavity, we won't have a clear view of the retina, or maybe there may be no view at all. We will not be able to visualize the retina at all. In such cases, optical coherence tomography or the photo-based systems also will not be able to view the retina. So what do we have at our disposal? It is sonography, because sonography can those waves can just penetrate, and it can form the reflections from those waves can form an image, an ultrasound image of the eye, just like sonography of your abdomen or your stomach, or when during pregnancy serial ultrasounds are done. Similarly, the ultrasound of an eye can tell us if we are not actually able to visualize what is behind in the retina. It can give us information on whether there is bleeding in the eye or not, and what is the status of the retina, whether it is attached. Retina is normally attached to the choroid. If there is a retinal detachment due to diabetes, the retina will be away from the choroid and we can see a retinal detachment happening there. So all these informations, so all these are called ancillary investigations which a vitreoretinal surgeon may prescribe to patients if needed. OCT, fundus photography, fundus fluorescein angiography, OCT angiography, and D-scan ultrasonography.
Nicely explained, sir. So now, as you are talking about that, diabetologists and general physicians also play a very important role in early detection. But what are the key clinical features? They don't have the all this thing to screen, correct? So what is the clinical feature that should alert clinicians or general physicians possible diabetic retinopathy progressions or macular involvement?
I will again say that clinical features, for a general physician, he cannot look inside the eye and detect if there is diabetic retinopathy. So any signs of diabetic retinopathy, we don't expect a general physician to pick them up. That's what we are here for. But if the patient is having symptoms, that is a decreased vision, or if he's having floaters, that is black spots moving around in the eye, or maybe something like one part of the visual field is black and he can't see properly in one part of the visual field. So these are very ominous signs. Because why do I say that these are very ominous symptoms? Is symptoms happen only in the vision threatening stages of diabetic retinopathy, which are either vitreous hemorrhage, diabetic macular edema, or attractional retinal detachment. So by that time, the damage is already severe and it needs a very urgent referral. So, but these are the signs that should be picked up. Diabetes can also cause cataracts. Posterior subcapsular cataract is very common and happens early as compared to uh, other people who have age-related or senile cataracts, and it is related to diabetes. So any decreased vision, we'll again count these signs so it will be easier to remember. Any kind of decreased vision, blurring of vision, metamorphopsia. Metamorphopsia means if a patient is seeing something, if there is a straight line, he won't see it as a straight line. It will look wavy or curved or distorted. So this happens when there is swelling in the central part of the retina. So three are done, and then any floaters, that is black spots, will happen if there is some bleeding in the eye. A partial loss of field of vision, it will happen if there is any retinal detachment, because retina may not be completely detached. One portion of the retina might be detached, which is responsible for a corresponding visual field which is on the other side. So if the nasal retina is detached and the patient is might be complaining of temporal blurring of vision or field loss. So all these signs are very important. And similarly, cataracts, posterior subcapsular cataracts, if they are happening, then the patient might complain of glare, colored halos, and things like that, because posterior subcapsular cataract is a cataract which happens in the posteriormost pole of the entire lens. Normally, cataracts happen and they cause opacification of the entire lens. This is called nuclear sclerosis, age related. However, a posterior subcapsular cataract is a very thick opacity. It does not let any light to pass through that much area where there is an opacity. And if there is any light passing through, there will be a lot of glare because there is something in the center which is scattering the light. So glare, especially while traveling at night, when you're driving at night, if you're seeing the vehicle lights from the opposite direction or just the street lights, they will be looking like glare and there will be colored halos. So all these symptoms are important. And the thing is, any symptom, all these symptoms are not only specific to diabetic retinopathy. These are symptoms which can be caused by diabetic retinopathy and they can be caused by any other things like macular hole, retinal detachment, any kind of cataract, glaucoma, corneal diseases. So eventually we have to look for whatever is wrong in the eye, diagnose those signs, and then treat accordingly.
Thank you very much, sir. Sir, coming to comorbidities, so how do hypertension, dyslipidemia, and renal disease influence the development and progressions of diabetic retinopathy?
So when we talk about all these diseases, they are very much related to each other. And these are all metabolic diseases or metabolic syndrome. They are classified under that common heading. That is diabetes, hypertension, increased cholesterol, that is dyslipidemia, renal diseases, and few cardiac diseases or emboli or thrombus, that is clots which are forming in the blood. So all these are related to vascular components of our body, that is blood vessels. If there is a damage to blood vessels, it will affect in all organs, and this damage can occur because of all these diseases. So that is how they are related. All these things are causing damage to blood vessels, and blood vessels are there in all organs, so all organs are getting affected. So now one important point is we can detect it early because as we said that eyes have blood vessels which can be directly seen by techniques of examination. Similarly, the other organs don't actually have very visible blood vessels. So if a patient comes to me with diabetic retinopathy, the first thing that I would do is control his all other risk factors, which are hypertension, cholesterol, and one more very important thing is homocysteine. So homocysteine can also lead to an aggravating effect on all these things. That is serum homocysteine. The levels of homocysteine can be increased. Just like cholesterol, we all know that cholesterol is harmful to our blood vessels, our heart, our brain, everything. Similarly, now very important thing has come, homocysteine. So I would definitely advise a homocysteine at a baseline as an investigation to check if that is an important risk factor. Secondly, nephropathy, that is renal affliction due to microvascular changes, is very, very common. We can say that this patient might have some grade of nephropathy if he's having this much severe diabetic retinopathy. So, a nephrologist opinion and a screening by a nephrologist becomes very important in this. If not, at least we have to see the function of the kidney, which can be done by renal function test, that is measuring the blood urea nitrogen, creatinine, and all these things. And blood pressure has to be checked. FBS and PP2BS for the blood sugars, whether it is being controlled or not. So, one more important thing becomes HbA1c. As we all know, what is HbA1c? It tells us the average control of diabetes over the last 3 months. So that is also very important because one day if the patient is getting a blood test and he has normal blood sugars on that day, that does not mean that he will have normal blood sugars throughout the next month or week. So if you want to look at the cumulative effect of what has happened over the last 3 months, we would get a HbA1c done. And HbA1c values ideally should be around 6. They should be less than 7, but at least less than 8 in a diabetic. If they're going above 8, then we cannot control. Because what happens is HbA1c, it is very difficult to control. As we all know, controlling diabetes along with medicines, insulins, there are so many patients who are trying their best also to control diabetes, but they are not able to control it. So 8 is a modest value. Below that, we should try to keep it. If it is less than 7, it is ideal. But diabetes can definitely be controlled if we have a holistic approach. And what becomes important is patient counseling and giving the patient chair time, speaking to the patient, having a dietitian reference done if his sugars are not being controlled in spite of him taking the highest amount of medication or significant amount of medications on insulin, then diet plays a very important role. So when we talk about diet, foods which have a low glycemic index, that is when they're absorbed in our intestine and they are in our blood circulation now, how much spike of blood sugar is a certain thing going to cause. So if you're eating something which has a lot of carbohydrates and very easily digestible or absorbable carbohydrates, which are not complex carbohydrates, then they will lead to a quick rise in sugar levels, and that will reflect in your blood sugar values. So we should avoid such very simple carbohydrates which are easy to digest. And that is what the diabetologists are also telling them. Eating maida or things like that, it becomes very difficult to control sugars. Instead of that, if you have a ragi bhakri instead of a maida, then it becomes easier for the body also to cooperate with you. So that is something we should be mindful of. Chai, tea is something that everyone loves in this country.
True.
So, and if we are having tea with milk and a lot of sugar is something which I would suggest stop having that. That is the most easiest form of this small cup of tea can increase your sugar levels very quickly. They will rocket. And then it will reflect in your HbA1c values. So maybe replacing tea with some herbal teas, lemon teas, or something like that. Having tea without sugar or having coffee without sugar, a black coffee, that would also help. And the thing is that sugar free, those chemical sugars which are there, which are ever ready or something like that, all those sugars which are there, which are not actual sugars but tablets of sugars, they have also been proven to be harmful and carcinogenic.
Hmm.
So these are actually compounds, and they can cause carcinogenic means they can cause cancer. They have been related to
Absolutely.
multiple cancers. So just substituting sugar by them and having it over the long run is going to harm your body too in a different way.
Best way to
So a
avoid the
holistic,
sugar.
yes, best way, not completely avoid, but at least limit your intake. As long as your sugar levels are being in control, you should keep on checking that. And diet plays the most important role. Light exercise and all these things, and meditation, yoga, all these things can also control your sugars by decreasing the cortisol levels in your body and shifting the metabolic pathways to ways which are beneficial in controlling diabetes.
Dr. Mihir, how do you decide between anti-VEGF therapy, corticosteroid, and laser photocoagulation for managing diabetic retinopathy and DME?
Okay. So moving on to the technical aspect again, anti-VEGF injections. What are these? These are anti-vascular endothelial growth factor injections. So these are used for the treatment of diabetic macular edema, and these are also used for the treatment of proliferative diabetic retinopathy. VEGF is something which is released when our retina is in a state of ischemia. When enough blood supply is not going to the retina, the RPE cells, the retina cells, they are all going to release this compound, and the vitreous is going to be full of this compound. Now, vascular endothelial growth factor, vascular growth, it has these two words in it. That is, vessels are growing because of this compound. This factor is necessary for the growth of these vessels, and this is going to cause the changes of diabetic retinopathy. So, for that, we can give anti VEGF injections which bind to this VEGF intravitreally. So, these are injections which are given inside the eye, and these capture the molecules of VEGF or the receptors of VEGF and thus prevent damage due to the excessive VEGF in the eye. So we have a lot of injections like bevacizumab, ranibizumab, we have aflibercept, we have brolucizumab, we have faricimab, and these are also the common trade names that we will be knowing for these in that order itself. So this was the order in which they came into practice. They were invented. This is the order which I said. So they would be Avastin, they would be Accentrix, Lucentis, or it could be an Eylea, or it could be a Paganax, or a Vabysmo. All these are brand names. So, what the goal of this therapy is to control the macular edema. Monthly injections are needed, but not for your entire life. What our goal is to initially give, say, 2 or 3 injections in the first 3 months, after which the macular edema is going to go down. And later on, what we are going to do is we are going to increase slowly the duration between 2 injections. So initially, if we give monthly, then we'll increase it to 2 monthly, 3 monthly, whenever needed. It won't be like if it's not needed, we won't give it 2 monthly. Our aim is to decrease the need for these injections by decreasing the diabetic macular edema and controlling it. So if your sugars are controlled, if you're following everything correctly, and diabetes and everything is causing less damage to your eye, the number of injections that will be needed will be also significantly less. So this is how we go about. We do an OCT scan at the beginning, have a baseline image, and we measure in microns how much the diabetic macular edema is. Then we inject if there is diabetic macular edema. When the patient comes to us second time, we look at the response. Has it decreased? If the diabetic macular edema has decreased, it is a good sign. But is it completely gone? If not completely gone, we inject again and we try to achieve a completely normal state of the retina. If an injection is not working in someone's eye, because every body is different, some body some retinas, they will respond to some kind of injections, some retinas will respond to other kinds of injections. So we might have to change the injection. If after giving 2 or 3 injections still there is no response, or if it has worsened, then we might have to change the injection from, say, a bevacizumab to a ranibizumab, or even a higher injection like Eylea. So Eylea, that is aflibercept, according to all the studies, Protocol S, Protocol T by drcr.net, which is a multicentric body, has been proven to be a long lasting and a very good FDA approved injection for diabetic macular edema. Similarly, ranibizumab, which is marketed under the trade names of Accentrix or Lucentis, is also FDA approved and has been proving to be giving good results in patients. For patients who are not responding to this, now we have two more injections. One is Eylea HD. Eylea HD means the molar concentration of the drug that is there in injection. There is only a limited quantity which can be injected into eye. We cannot give 3 times Eylea injections at one sitting, because that will increase the intraocular pressure and it will have side effects also. So if we increase the concentration of the drug and make it more potent, so that would be Eylea HD. Instead of 2 milligrams, it will have 6 milligrams in the same 0.05 ml. So that is one thing. And the latest thing which has come in is Vabysmo or faricimab. So what does faricimab do? It not only acts on the VEGF receptors, but also has an effect on Ang2 receptors. When it acts on Ang2 as well as VEGF, these two pathways are they work with each other and decrease inflammation as well as the VEGF load, giving a better response. So currently in my practice, I have reserved faricimab injections for those who are not responding to the conventional anti-VEGF therapy. And the third thing that we have is steroids. Depending on the OCT, we have a certain few biomarkers like multiple high reflective foci or disorganized retinal inner layers or something like that, which we see on the OCT, and then we decide whether to inject a steroid in the eye instead of an anti-VEGF. So steroids also work very well. Ozurdex is an implant which can be injected into eye. Similarly, fluocinolone is there, and the cheapest form of steroids is triamcinolone acetonide. However, I prefer not to give triamcinolone acetonide to patients unless they are uh, not affording at all, or they are completely, we have tried everything else and then we are giving IVT, because it has a lot of side effects, especially pressure spikes in the eye. The intraocular pressure can be suddenly increased and then it becomes difficult to control it with multiple medications also sometimes. For some patients, it might not have any side effects at all. Some patients might respond very well, because that is how side effects work. They are not effects, they are sometimes, they happen in some patients, they are idiosyncratic reactions. So similarly, one more disadvantage of triamcinolone is that it can aggravate the cataract, or it can form a cataract if it is not there. So in pseudophakic eyes, that is those eyes who have already undergone a cataract surgery and have a lens in their eye, this risk is completely eliminated. Because how can a cataract form now? We have already removed the cataract and put a lens in. In such patients, if they have diabetic macular edema, then the threshold for giving a steroid injection, it decreases, and I can safely give steroids and only be worried about the glaucoma part. So after giving steroids, one thing I'll do is I'll call the patients for follow up more frequently and keep a look at their pressures also, if they are increasing or not. If they increase, I will try to control it with medications. And after the steroid effect goes, the steroid side effect also goes. So it won't cause any permanent damage or anything to your eye. But yeah, that is one thing we should be watchful of. So this is how I treat diabetic macular edema with injections. For should I tell about lasers also? Because lasers, they form a very big part of managing proliferative diabetic retinopathy. So when a patient comes to you with PDR, what has happened to his eye is his retina, which is the peripheral retina, has gone into a hypoxic ischemic state. Now, the peripheral retina is not very important for the vision. It is only important for certain things like vision in the dark, contrast sensitivity, this, that, etc. So, what we do with laser is that we give laser therapy to that retina, and some parts of that retina, not a confluent laser therapy. These laser burns are spaced apart so that some part of the peripheral retina is still working. So these lasers are given to the retina and they convert this hypoxic, that is a retina which is in oxygen demand, to an ret- anoxic tissue. Anoxic tissue means now we have burned that tissue, now the demand is less. But the thing is that tissue was not as important as the central tissue which we saved by burning that tissue, and we have not burned it completely, so it will not lead to a loss in field or significant problems for the patient. And that is the treatment which is going to work the best for proliferative diabetic retinopathy, because an injection, if you give, it will stay, and then it will stay for say 1 month, for 2 months, and then it will be gone, then again you will have to inject. So it is not a definitive permanent treatment for proliferative diabetic retinopathy. However, we can use it in conjunction with lasers, but lasers on the other hand give a long term benefit, and that is what we do as a first line of management in our country, and it is the best therapy for proliferative diabetic retinopathy. You're muted again, sir.
Yes. So thank you very much, sir. You have talked a lot about medical management as well as you also added, laser therapy. So coming to the surgical management, in which scenarios of virectomy, vitrectomy indicated, and what are the key consideration for timing and outcome?
Yes. So vitrectomy basically is removal of the vitreous from the eye. So in a diabetic retinopathy, when it becomes proliferative, as we all know, the hemorrhage or the bleeding that can occur, that will be in the vitreous. So sometimes what happens is if the bleeding is very less, it can get absorbed and resolve on its own. So in such situations, what we do is we wait for some time, tell the patient to sit or sleep in a propped up position. We give vitamin C, which increases the absorption and resolution of vitreous hemorrhage, and we try. So for 1 month, we can wait and watch. After that, what will happen is if the bleeding is reducing, the vision is improving, we continue to wait and watch further and try to manage with medical therapy. But if it is same or it has worsened, something like that happens, then we have to actually go inside the eye using vitrectomy machines, and we have to make ports in the eye and go behind and then clear all the blood and then laser off the retina so that we have a permanent defect which prevents bleeding again. So that is one indication, vitreous hemorrhage. Another indication would be a tractional retinal detachment, especially that one which is affecting the macula. So what happens is these neovascular blood vessels they start proliferating, and there is a fibrous component that happens because of the leakage, exudation, and everything that is happening from these vessels. So now when they fibrose, they can start contracting. When these blood vessels and the fibrovascular proliferations on the retinal surface start contracting, they, because they are attached to the retina, they are going to pull it up. So if you attach a tape to a cloth and then just contract it, then there will be wrinkles in the cloth, right? Because it is attached at multiple points. Similarly, the retina starts getting wrinkled and eventually gets detached from the underlying choroid. Now, this is what we call a tractional retinal detachment. Now, what happens is if this tractional retinal detachment has come to the macula and is detaching the retina on the macula, then it will lead to a vision threatening disease, and the damage due to this may be permanent also. So for such situations, and for situations in which it has already started contracting, for situations in which it is threatening the macula and already it has affected the macula, we proceed with vitrectomy, in which we remove the gel inside the eye completely first, and then we remove the posterior most membrane of this gel, that is the hyaloid, over which all these fibrovascular proliferations are growing, and then we flatten the retina and we put some kind of a tamponade if needed, and we laser for the proliferative part using pan-retinal photocoagulation, and barrage laser if necessary for any breaks or holes which are formed in the retina. The third type of detachment is when the tractional component has contracted and it has also caused a tear in the retina because of the contraction, not just crumpled the retina or elevated it. So this is called a combined rhegmatogenous and tractional retinal detachment. In such cases, we don't wait and see whether it is threatening the fovea or the macula or not. We just go in because it is going to progress. Purely tractional detachments which are not affecting the macula can be managed with laser and injections. But these detachments which are combined, there is already a hole formed. Now, what is going to happen is the vitreous is going to liquefy, and this water form, the liquid form of vitreous is going to go into that hole and detach the retina further from the underlying choroid, and it will turn into a very bad retinal combined detachment. So any combined detachment will go in and operate.
Thank you very much, sir. Sir, how can ACP improve the patient adherence to regular eye checkup and treatment plan, especially in asymptomatic stages?
I did not get your question. How can a
How
what
can
improve adherence?
ACP, a doctors, improve the patient adherence to regular eye checkup and
Okay, okay.
treatment plan, especially in asymptomatic stage?
Yes. So patient education is very important. It is very important to take your time when you have a patient and speak to them and try to simplify all these things and then tell them. So some patients might be interested in knowing everything, going into the details. For those, you tell them in detail. For some patients whom you think would not be interested in knowing the pathophysiology or something, at least to tell the complications and simplify it as much as you can, so that they know that we don't have to wait till something happens and we start noticing it. So symptoms, we don't have to wait for symptoms. We need to have an annual checkup. And similarly, there can be things like a diabetologist can write in his findings when he's seeing a patient. Say he's seeing a patient every 6 months. Every time he can try to make a note of whether he has seen an ophthalmologist, whether his screening is on or not. And every time when multiple doctors that a patient is visiting tell that patient that it is something important, and the patient also realizes. Similarly, what layman can do is on YouTube or multiple other platforms, there are animations which are there, which simplify. And once you can visualize, because for us doctors, we are seeing the eye and we have studied the anatomy, physiology, we are very much easily understanding the pathology that is happening. But the patient has to be taught the physiology and anatomy of the eye in very simplified terms with maybe animations, AI generated videos, or just models of eyes, so that they understand what is happening and why it is actually necessary to not wait till symptoms are coming. And a holistic approach is needed. So, as a doctor, as an ophthalmologist, it is my job to make sure that the patient is controlling his diabetes also. I can't be like, no, I will just treat the eye. I won't care about the patient's diabetes. Similarly, a diabetologist or a general physician also has that job to see if he is getting an eye checkup done and getting anything detected before it becomes grave. So doctors also need to have this in the back of their minds and stress upon it multiple times so that the patients will know the severity and need for screening.
Dr. Mihir, I think you mentioned it in the beginning of this session that teleophthalmology. So, how do you view the role of AI and teleophthalmology in expanding their screening access, especially in rural or resource limited settings places?
So in the last 3 to 4 years, teleophthalmology has been going on for the last 10 to 12 years. AI has come in the last 2 years. So in the last 2 years itself, there are so many new softwares which have come up, like IDXDR or say a Remedio or a Retina AI Galaxy. All these are softwares in which fundus images can be taken with a camera and uploaded. So what AI does is AI just has a database of multiple patients with normal retinas and multiple patients with different stages of diabetic retinopathy. It matches the image of the patient with its entire database, a million cases of database it has, and it tries to figure out what stage it is in. Now AI has become fairly accurate to telling us what stage it is in. If not, at least AI or all these teleophthalmology or fundus camera based systems and software can tell us if it is necessary to visit your ophthalmologist or not. Because the final treatment and decision making is going to lie in the hands of ophthalmologists. We cannot leave it to AI because sometimes things can be missed. So it has had a very great role. So what we do is what a machine does is it can either capture the photo of the retina in a dilated stage and now even in a undilated pupil through that small window of the pupil also it can give good images. Fundus photos can be having a small field, only the posterior pole. They can be a wide field, they can be ultra wide field, and they can be optos fundus photos also, which show up to the ora serrata with great detail. So all these should be used, and there they should be setups, at least the ones which are affordable and economically efficient. They should be set up in rural areas in the PHCs and general clinics. And teleophthalmology can be done by consultants sitting in the cities or wherever the doctors are more and they're available. You can just sit in front of their screen. Just like retinopathy of prematurity is being done, this also can be done very well.
Thank you very much, sir. Sir, coming to the closing sessions, closer part of this session. So, what are the some emerging therapies or preventive strategies that hold promise in the future management of diabetic retinopathy?
So, emerging therapies, as I just said, there are many implants which are coming in. Now, implants, they increase the duration or decrease the frequency at which injections need to be put because they are slow release implants. You can put these implants in the choroid, in the sclera, in the suprachoroidal space, wherever there are multiple places in which you can implant them, and these will release the drug slowly. Just like there are if you talk about pantoprazole, which is a tablet, it can be immediate release or it can be sustained release. A tablet can do the sustained release for how long? A day or something. Similarly, an injection can act for a month. However, these implants can act for 3 or 4 months. So what happens is patient compliance increases. Every month going in and taking an injection, so it becomes a burden, and 1 month becomes 1.5 months. Sometimes it becomes 2 months. In an ideal case scenario, you should screen at 3 weeks, and the injection should be scheduled and it should go at 1 month. So that is how all the studies are being done, and the results have been published. But in a real world scenario, this can become to 1.5 months, 2 months, 3 months. So in these cases, it becomes important to have a sustained release option also making it available to the patient and the doctors. So this is one thing. In lasers, very good thing that has happened is micropulse lasers. So normally a laser goes, hits the tissue of the retina, it burns it and renders it anoxic. or we can give a sub-threshold one, but there is some damage to the retina because of that laser if given close to the center of the macula. Now, micropulse lasers, they just stimulate the RP and increase the efficiency of retinal pigment epithelial pump, preventing the macular edema. And they should be tried in conjunction with injections for diabetic macular edemas to again increase the duration between two injections or else have a better effect. So these are the two things that come to my mind when we speak about recent advances and changes in the technology that have come in the last few years.
Thank you very much, Dr. Mihir Vaidya, for your insightful sessions and guidance and recommendation on diabetic retinopathy, sharing your expertise and excellence. Nice session. I'm sure this will help ophthalmologists across India to utilize this learning in their day-to-day practice. And those who have missed this Knowledge Fields event can see it recorded on DocPlexus platform on the past event tab. With this, I request Dr. Vidya to say some final words and close the session.
Thank you so much, sir. The questions that you asked me, they were very nice and they were very not too technical also, and they could be. I could say some things which could be understood by all kinds of doctors and even laymen if they are interested in that. Even patients can benefit from this. So it was a very nicely structured webinar which you put through and conducted. And eventually, patient education is important for primordial prevention, primary prevention, and however advanced we keep on getting in the treatment, if we can prevent diabetes, then we don't need it. And that is where our focus should be. And that will come with a united, holistic team effort. And you, with such webinars and podcasts, are doing it. And similarly, we'll keep on doing more so that we
Thank
can
you very
benefit
much.
the patients, the general practitioner,
Certainly,
and
sir.
fellow
Certainly, sir.
ophthalmologists.
Certainly, sir. We'll also plan for the patient part, sir,
Yes.
obviously.
Yeah.
Thank you very much, sir. Thanks a lot for your time.
Thank you so much.
Thanks.